CVS Part 1 Case 4.
A 55-year-old male with prior MI treated by PCI and dual antiplatelet therapy presents with acute ulnar artery thrombosis on angiogram in unusual distal site, causing ulnar-sided numbness. It resolves promptly with heparin infusion despite ongoing DAPT. Prior thrombophilia screening, which includes protein C, S, functional assays, lupus anticoagulant, anticardiolipin, IgG, IgM, beta-2 glycoprotein, ANA were negative. Echo shows no clots. CT, chest, abdomen and pelvis is normal. No evidence of malignancy, adenopathy or splanchnic clots. Daily urine dipstick shows traces of RBCs. Microscopy is negative for no clots, dysmorphics or no proteinuria. Labs includes hemoglobin is 10.2, WBC count is 4200, platelets are 98,000, LDH is 480 and reticulocytes are 4.2%. Heptoglobin is less than 10 with normal bilirubin, D-dimer, APTT, PT, INR and fibrinogen. Peripheral smear shows normocytic anemia, no schistocytes, no Role formation, no blasts. Serum protein electrophoresis shows normal polyclonal IgG. What is the single most appropriate next diagnostic test? Option A, renal biopsy for isolated glomerular hematuria. Option B, bone marrow biopsy for unexplained cytopenias. Option C, high sensitivity flow cytometry for GPA anchored proteins, which includes CD55, CD59 and FLAIR on peripheral blood cells. Option D, homocysteine, lipoprotein A and factor 8 levels. Option E, repeat ADAMTS13 activity despite prior low normal results.
So this is a case of PNH, paroxysmal nocturnal hemoglobinuria, which is a clonal hematopoietic stem cell disorder marked by a mutation in PIGA gene, leads to deficiency of complement regulatory proteins like CD55, which is also known as decay accelerating factor, CD59 known as membrane inhibitor of reactive lysis, and FLER proteins, FLAIR proteins. So now we need to understand that if there is a deficiency of complement regulatory proteins, then what we'll get? We'll get three things. We'll get intravascular hemolysis, which is evident in this case by an increased LDH, decreased haptoglobin, increased reticulocyte count, no RBCs and casts in urine microscopy, presence of blood hemoglobin in urine dipstick. Second thing is thrombosis at unusual sites like in ulnar artery in this case. Now what is the reason for this thrombosis? It is due to complement-led platelet activation. So as we can see in this case that the patient is not responding to dual antiplatelet therapy but immediately responds to heparin. So that proves that it is not direct platelet activation which is leading to thrombosis here. It is complement-mediated platelet activation which is leading to thrombosis. Other factors leading to thrombosis are the free hemoglobin available scavenges the nitric oxide and the endothelial dysfunction also triggers thrombosis. Now the third complication in PNH is as there is clonal hematopoiesis which leads to chronic bone marrow failure and thus resulting in cytopenias. So all these things happening in PNH. Now to summarize that, Dr. Sarita will tell what is the triad of PNH.
The triad of PNH includes intravascular hemolysis, thrombus in unusual sites, and third one is the clonal hematopoiesis which is overlapped by marrow failure leading to pancytopenias.
Yes.
These three together known as the triad of PNH.
So as we have understood the triad of PNH, now we'll exclude the options. So the option A that says that this is due to isolated renal hematuria. So we can see there is no hematuria. We are not getting RBC casts in the urine. and there is no mention of dysmorphic cells in the peripheral blood smear, and there is no evidence of renal insufficiency. So option A is ruled out. What is option B?
Bone marrow biopsy for unexplained cytopenias.
So we can see that bone marrow biopsy is not the first step of diagnosis in this case. What is option C?
High sensitivity flow cytometry for GPI anchored proteins. C.
This is the correct option, that the next diagnostic step is high sensitive flow cytometry of the complement regulatory proteins which are deficient in this case, that is CD55 and CD59 and flare proteins. Now out of these three, CD55 and CD59 are expressed on the RBCs. Now RBCs can be lysed or transfused in this case. So more specific are flare proteins which are expressed on granulocytes. So we will go for a high sensitive flow cytometry for flare proteins more specifically and less specifically for CD55 and CD59. Now what is option D?
Homocysteine, lipoprotein A and factor VIII levels.
Homocysteine, lipoprotein A and factor VIII are atherothrombotic and vascular risk modifiers. So these are of no benefit for PNH. And coming to option E, the ADAMTS13, this tells about an enzyme which cleaves von Willebrand factor and is deficient in TTP, thrombocytopenic thrombotic purpura. So this is not a case of TTP, this is a case of PNH. So this is correct, that we'll go for a high sensitive flow cytometry for CD55, CD59 and flare proteins. Thank you.